And all right. So again, I am Crystal Nicole Donovan. I use she, her pronouns, and I am going to just spend a few minutes talking to you about changes in gender affirming care and action steps to mitigate any harm. These are our objectives: identify gender affirming care, describe changes, and then identify action steps, which is always my favorite part of the presentation. Yesterday, I was part of a panel, and we were specifically talking about LGBTQ plus students. And I was asked when I was entered to introduce myself to talk about like why is this topic important? Why am I here with you this afternoon? And I told the audience that my first hairstylist was a Black trans woman. She was this beautiful spirit and she had such nurturing hands. And I was a very small individual. And I do want to ask that you not judge my mother. I had a lot of hair and she needed some help. And so she would bring me to this amazing individual, and I just love this person. And even though I didn't have the language as a child, I quickly learned that while I thought that she was amazing, not everyone felt the same way. And also, I quickly learned that she was not necessarily safe in all spaces. And so, as I said, I talk a lot about first episode psychosis, and I was listening to Dr. DeLuca, and something he said that might seem simple, but is still profound. He talked about culture and psychosis being intertwined. And you can replace that. So, if we're talking about culture and mental health more broadly, and then to extend that even broader, culture and health are intertwined, and want to think about how people should be able to show up as themselves in all spaces. So even when they walk in your doors, when they walk in your lobby, walk in your offices, how they can feel safe and affirmed. So again, culture plays an important role in gender and sexuality. And also for the programs that I work with, typically individuals are eligibility criteria is 15 to 40. Typically, individuals are about 15 to 30. And so, just want to think about how gender and sexuality can develop across the lifespan. And also, it can be a time for exploration, learning through trial and error. And again, individuals might have changing needs over time. So we could spend an hour just talking about gender affirming care, but I'm going to try to sum it up in a couple of slides. According to the World Health Organization, gender affirming care encompasses a range of social, psychological, behavioral, and medical interventions, but ultimately is designed to support and affirm an individual's gender identity. So when we're talking about gender affirming care, it can mean many things. So as we think about maybe what we've heard in the news or what we've read on social media, oftentimes there's been a focus on one area. But again, there is a range. When you think about the providers and the clinicians that are on this call, you provide a range of services that all falls under healthcare, right? And so we want to also think about that in regard to gender affirming care. Again, according to, think about the World Health Organization, really it's just patient-centered care. So I talked about how I am a social worker by background, and so I'm not a clinician, but I talk to many clinicians, and many of them are simply saying it's what we already do, Crystal. It's just person-centered care. It's honoring an individual's autonomy, their self-determination, and providing a little compassion for the individuals that walk through our doors. So again, it can feel like this very abstract idea, but many people are doing it even if they're not actually identifying as gender affirming care. And just want to identify that American Psychiatric Association basically is saying the same thing, that really gender affirming care is a therapeutic stance that is really focused on affirming the individual's gender identity and not trying to repair it. And so to just give a little more concrete example, so it could be something just as simple as having a conversation, in regard to an individual being able to change their name on their birth certificate, on their driver's license, or their ID. And according to the Trevor Project, those conversations and then ultimately those actions um, can decrease rates of suicide. And then also, things that, and I even had to remind myself yesterday, we were talking, pronouns do matter, names do matter. And again, what Trevor Project and others have consistently shown is that, again, if one feels affirmed in those areas, then there is an association with lower rates of suicide. And so I wrote, like, when you're thinking about just your documentation, your electronic health record, when somebody walks through up to the front desk, is there a way to be able to honor their name and their pronouns in that record, even if legal documents might read differently? And that's something I constantly am kind of challenging individuals, like as we're having these conversations, what position does your specific discipline take? I can talk about National Association of Social Workers, but when you're thinking about, interacting with people, most of us, have a code of ethics. And not only do we have a code of ethics, you think about the institution or the organization you're part of as well. And so really, digging in, going back to code of ethics, looking at your code of conduct within your organization, and kind of thinking about how does this conversation in regards to gender and gender identity fit into that? Because I recognize, like, this slide, it might seem like I'm repeating myself, but really when we know that youth and young adults have LGBTQ plus have high rates of thoughts of suicide and then attempts, we really want to think about kind of like what role do we play in being able to truly support their mental health and ultimately their well-being. I have just a couple of slides, and it's just like I don't really feel like I'm giving justice to the impact of stigma and discrimination. But what we know is 1 in 5 transgender non-binary youth attempted suicide. And when we're looking at Black young people as well as other young people of color, their rates are even higher. So again, there's not one single story when we think about trans and gender nonconforming young people. So someone like a Black trans man is going to have a different experience than his white peers might have. Also, 60% of LGBTQ youth who wanted mental health care in the past year were not able to get it. So we really just need to think about access more broadly. How are we outreaching individuals, and ultimately, who are we missing? I know in my work, I am constantly reminding individuals that we need to think outside of hospitals, really thinking about who are those community members and those grassroots leaders that we need to be in relationship with. And then also, we don't always realize that youth, young people, young adults, like, they're paying attention. And so just all of the things that we're reading and we're hearing in regards to changes that are happening, not just in Ohio, but across the country, nearly 1 in 3 LGBTQ plus young people said that their mental health was poor most of the time or always due to anti-LGBTQ plus policies and legislation. And then nearly 2 in 3 young people said that hearing about potential state or local laws banning people from even discussing LGBTQ plus people at school made their mental health worse. Think about, like, who you are, and all of a sudden individuals, saying that we cannot even discuss, right? So just challenging your humanity and what impact would that have on your mental health. Changes in practices, and as was mentioned earlier, things are constantly changing. So I'm specifically talking about changes that are happening now and proposed to happen in the next couple of weeks. So there's a recent change which created this diagnosis of gender-related conditions. And this is very specific to Ohio, so I really want to emphasize that. And it means any condition, and this is specifically for minors, where a minor essentially saying their gender identity and their biological sex that all of a sudden is not aligning. And it could include gender dysphoria. So gender dysphoria is, if you open the DSM, you can find gender dysphoria in there. However, you will not find gender-related condition. Also, since you cannot find it in the DSM, when you think about ICD-10 and your diagnostic codes in regards to billing, one is not going to be able to bill using gender-related condition, and that matters. So again, there's like when a diagnosis is all of a sudden being created and going out into spaces, and there's mandates behind that, that can be really challenging, obviously, for the people receiving services, but then also for clinicians as well. So one thing that's come out in Ohio, the changes prohibit medical gender care. So puberty delaying medication, hormone therapy. There are exceptions for individuals that are already receiving care. So for anyone that is new to service, maybe anyone that was on a wait list, those individuals would not be able to receive these services. But again, there are exceptions made for individuals that are already receiving care. And unless something changes, so I just want to say that the effective date is April 24th, 2024. Also, changes prohibit Medicaid care for transition services for minors. Really want to stress for minors. However, there is an exception for mental health care. So one of the changes, and again, we're talking about kind of conflicting principles. We're thinking about standards and regulations that are already in place. A change that has really been highlighted is no mental health professional shall diagnose or treat a minor individuals who present for the diagnosis or treatment, again, of that gender-related condition. And so there has to be at least one parent, at least one legal guardian, or the individual's guardian. And someone might think, well, Crystal, shouldn't that happen anyway? Well, you want to think there might be times for many different reasons that maybe just the minor individual isn't sure. Maybe the minor individual isn't feeling safe at home. And so there have been, up to this point, regulations that would allow someone 14 and older to be able to at least start asking questions, to at least initiate care for, I believe it's 6 sessions or 30 days, whatever is longer. So again, it's just showing some of those conflicts in regards to existing regulations and then some of these more recent changes. And then I'll be honest, when I talk to a lot of clinicians, they were almost offended by this recent quote unquote change because this is just best practice, right? They're like, of course, when we're diagnosing or moving forward with treatment, that we're screening for comorbidities. That is just part of standard practice. I would just add that it just makes me want to encourage everyone to be more clear and more concise in their documentation. So want to stress that it's not for specifically, we're talking about like mental health interventions and practice and care. That can continue, but your documentation, consultation, supervision, that's really, really going to be important with these new changes coming down the pipeline. But I believe that there are always things that we can do, right? We can do better. And so I would say we all can be trauma informed, regardless of your discipline, your role, that when you're thinking about safety, I know we throw that word around a lot, really just asking participant what makes them feel safe and what makes them feel unsafe. Having conversations about how people prefer to be addressed, acknowledging that building relationships takes time, right? So we're always thinking like we have this really good service. I think about the work that we do, but then I also have to remember that one, like people don't know us. So we're like, hey, come see us. We're offering some really good things. And then also we want to acknowledge that some people have had some really bad experiences, within that healthcare system. So it might make them a little apprehensive. Oftentimes I'll hear people talk about like their Black participants or their Latinx participants maybe have a lot of mistrust, but I do challenge them. And, so we have to start having conversation about what we know in regards to not just history, but also like very current practices and how oftentimes that mistrust can be very legitimate. Um, I just said last week is that I try not to say voiceless. So we're talking about giving voice. Everybody has a voice. There's just some individuals that we are not listening to, and or they have not felt safe speaking up. Peer support, we can have a whole didactic on peer support. Can't really stress enough the power of peer support, but it doesn't always have to be within your organization. It doesn't always have to be that person that's gone through, those numerous hours of training and has been certified. Again, really thinking about who are those individuals in your community that also can provide that support. And also when we think about people, all of us are individuals within a system. So who are individuals, in the community or that might be part of someone's other chosen family, or when we think about faith institutions that could also be part of treatment. And then Block et al., this is where I initially just got some of this language, but they took this trauma-informed practices from SAMHSA. And so this is pretty consistent. Again, really want to highlight that we also want to be aware of how current and social political events might be activating with the individuals that you're working with. Again, a huge part of coordinated specialty care is shared decision making. So this is not anything necessarily new. Again, acknowledging and help clarify participants' preferences, their values, and then providing individuals tools, right? We shouldn't be in these roles to just help people or just to come in and try to save individuals. We really want to be able to provide the tools for participants to be able to take an active role in the decision-making process. Your electronic health record, I touched on that earlier, just thinking about how that can be a support. Is there a separate space where you can add a name or to be able to change pronouns? Thinking about your front desk, providing them the education they need, they want to, based on my experience when I was in outpatient, they want to be sensitive, they want to be affirming, they want to provide a safe environment. So how can you also include them in the process? And just your physical environment that can play such a vital role in, if someone's walking through your doors, how are they feeling those first just like 30 seconds? I had a training several years ago, and one of the things that the facilitator said is that when he walks in a building, he always looks at the pictures on the wall. And so now when I walk in a building, I always look at the pictures on the wall. And I'll be honest, oftentimes I don't see myself, right? When I'm seeing like, who are the top leaders? Who are the individuals in the C-suite? Who are the last 10 presidents, right? Like really some of those visual cues really can make a difference in regards to engagement and retention. Thinking about gender neutral restrooms, really that just like is a single restroom. It's just like where my physical office is across from me, there's a restroom that could be used for many individuals. So it's an accessible restroom for everyone. And even as we think about some of our new families in our community, where many of us are wearing multiple identities. So, as I mentioned earlier, many individuals are, they're layers. There's not a single story. And so you might have someone that needs interpreting services, but also want to make sure that whomever is providing those services is also sensitive to LGBTQ plus issues. Really can't stress enough cultural humility opposed to cultural competence. We're never going to be competent in someone else's lived experience. And cultural humility is just really about, this is an ongoing journey. It's really about a lot of self-reflection. So for all of us as an individual, but then also I'm a systems person. I believe at looking, upstream. And so it's also about how are we advocating, whether that's within our institution or also outside of our institution. So ultimately, everyone is feeling safe and affirmed. And then culture formulation training, that is something that more individuals are using, specifically just when you think about not just coordinated specialty care, but just kind of throughout the mental health spaces. And it has been found to really provide some clarity in creating in that diagnostic experience. Because if you're able, you think about if you're able to provide as much as possible, that process is not perfect, but able to provide a clear diagnosis and being open and honest with individuals, again, they're more likely to trust you and they're more likely to come back. And then one of the last things I'll leave you with is like everything is going on, and I'll be honest, a lot of it can feel heavy, but I believe that we can do better. I believe that we can start reimagining how we do the work, and just thinking about people able to be able to receive services in a timely manner, resources, services in a timely manner, but also just thinking about concrete services that maybe we are like, oh, I know a shelter, but is that shelter inclusive? Oh, I know a place for respite. Again, do they provide inclusive services? When we're thinking about people outside of the walls of the organization, looking at organizations that are led by transgender and gender nonconforming individuals, and then really want to stress the importance of chosen family and community. Who are some of those individuals that are really going to be supportive and wrap their arms around the participant? Because ultimately that's the goal, right? I used to like joke about when I was an outpatient that, we're here 9 to 5, Monday through Friday. So let's start talking about some of those individuals that really are going to be able to lift you up and support you. And then I just want to say that I do believe that another world is possible. It's not only possible, at this point, I would say that it's necessary. So thank you for spending this time. Again, I'm Crystal Nicole Donovan. And if you want to talk more about coordinated specialty care, here is my contact information. And I am going to end my presentation at this time.